Hi, my name is Cindy Sanders, and this is my clinical case study for Nurse Practitioner Role 1. So this is an 18-year-old female who was brought in with a chief complaint. They said I was naked, chasing the cops with a frying pan. This is an 18-year-old single Caucasian female who was brought to the emergency department by police after her neighbor called 911. The neighbor told police that the patient was acting unusually, making verbal threats and expressing paranoid and persecutory beliefs. When the police arrived at the scene, they found the patient running down the road naked. The patient reported using a lot of meth today. When the police brought the patient to her home to get clothing, she began chasing the police officers with a frying pan. This was the first admission to the behavioral unit for this 18-year-old female. She has no prior psychiatric history and does not take any daily medication. She presents for the interview tearful, saying she just used a little meth the other day to get things done. I don't know what happened. She reports she does not remember running down the street naked and says this never happened before. Regarding attacking the officer, the patient reports she is embarrassed about her behavior. She denies experiencing hallucinations or feeling paranoid, however, was picking at her skin during the assessment, asking if staff could see the bugs. She required 2 milligrams of Ativan and 5 milligrams of Haldol IM before she was cooperative enough to accept IV fluid hydration. Medical workup has been within normal limits, and the urine toxicology testing was positive for methamphetamines. The patient has been admitted to the acute inpatient behavioral unit under a PEC status for observation. So, general review of systems, everything was normal, with the exception of the skin, which had extensive excoriations of her face and arms and track marks noted to both of her arms. The patient reported that she had had problems falling and staying asleep for 3 days prior to admission, estimating that she had 3 hours of sleep per night with no naps. She says that she feels helpless and hopeless and worthless due to her current situation. Decreased energy. She says she has feelings of fatigue, decreased appetite, and her psychomotor. She is restless, fidgety. She was found naked, making verbal threats, expressing paranoid and persecutory beliefs. Mania, she has an elevated mood, a decreased sleep, and pressured speech. In reviewing her history, social history, the patient is single. She has no biological children. She reports living with a male roommate in a rented home near a college campus. She is currently unemployed with no source of income, saying she lost her job at the gas station 2 days ago. She says that she is an only child and was raised by her biological parents. She reports a normal childhood. Parents are supportive and concerned. They state she was raised in the Baptist faith but does not currently practice any religion. And the patient says that she enjoys working with her hands, making things, and sewing in her spare time. She has no allergies, no significant medical or surgical history. She does not have a past psychiatric history. Substance abuse history. She denies alcohol use, denies tobacco use, but does report using meth on occasion intravenously. Never had substance abuse treatment. No history of trauma other than her girlfriend broke up with her 2 weeks ago. She's upset over that. Everything else is relatively normal. In reviewing family history, there's no family medical history that's significant. The mental illness, substance abuse side of family history, maternal grandmother had schizophrenia, paternal grandmother had bipolar disorder, no history of suicide, also no history of substance abuse. As previously stated, urine drug screen was positive for amphetamines. Other diagnostic labs were within normal limits. Mental status exam, positives there. The attention concentration, the patient had nonlinear conversation. She was able to answer questions with frequent redirection. She did exhibit some thought blocking while she was speaking. She would stop suddenly and remain silent, kind of losing train of thought. She voiced feelings of persecution, that people were coming to get her, that she did something bad, and then she asked if we heard them talking. She also exhibited formication, which was, she said, bugs were crawling under her skin. Um, she was preoccupied and constantly was looking around the room, saying, "Do you hear them laughing?" She looked very downcast, anxious, nervous. When asked if she's anxious or nervous, the patient denied that, but she was tapping her foot and just very restless, hyperactive. Speech was spontaneous, pressured, excessive. Judgment and insight were impaired. She is unaware of her symptoms, and she blamed her whole admission on a misunderstanding. She says that she only used this method, every once in a while, and that couldn't possibly be her problem. While she's been on the unit, she has been having issues socializing with other people, hiding in her room, not participating in groups. So, in no particular order, some of her very many stressors. Primary stressors are drug use. She's got psychosis, altered perception. She does have anxiety related to hospitalization. The stigma of drug use, being picked up by the police, brought to the hospital. And then she has the issue of she was violent towards her neighbors, going back to live there. The roommate saw everything, and the police. So looking at everything, we do have some liabilities. Our patient exhibits lack of coping skills, poor judgment, limited insight. She is unemployed. She doesn't really practice any kind of religion at this point in time, and we're not really clear about her motivation for change. But she does have some protective factors we need to discuss. So looking at her assets and strengths, she does have general fund of knowledge, seems to be fairly intelligent, good physical health, good communication skills. She's been cooperative. She does report having some hobbies. She likes to sew, family, very strong support system, and she is capable of independent living. So this all leads us up to our differential diagnosis. So first, it could be substance intoxication or substance withdrawal, because she does have a positive drug screen for amphetamines, but she does not believe her perception has been altered by those drugs. So that's going to rule that out. The next possible thing is a primary psychotic disorder. She does exhibit clinical characteristics of hallucinations and delusions that are similar to primary psychotic disorders like schizophrenia. She is, unfortunately, she's positive for methamphetamines, which is known to cause those symptoms of delusions and hallucinations. We looked at psychotic disorder due to another medical condition. The supporting data for that, the patient was exhibiting hallucinations and delusions associated with certain medical conditions and diseases, but negating data, the patient had no previous medical history and does not take prescribed medication. So that leaves us with amphetamine-induced psychotic disorder, because she is exhibiting clinical characteristics of hallucinations and delusions, and she does have a positive drug screen, and there's no negating data for that. Given her diagnosis, our assessment and plan, Treatment should focus both on alleviating the psychiatric symptoms as well as promoting abstinence from methamphetamines. And our long-term goal here is to prevent relapse. So just a quick review of literature. Best practices for management in an acute setting. Anybody that's previously healthy that comes in with an acute onset of psychotic symptoms requires a comprehensive evaluation. They would need brain imaging, laboratory work, including basic metabolic panel, HIV, rapid plasma reagent, and thyroid stimulating hormone, because those help rule out possible medical causes. So we've already done that. We know that her drug screen is positive, and she has gotten the IV fluids that would be needed to replace fluid loss and address the hyperthermia caused by methamphetamine intoxication. We want to look at possible withdrawal from alcohol or benzodiazepines, because both of those can present with psychosis. And methamphetamine is often used in conjunction with other substances, so we need to rule that out. And benzodiazepines are the preferred treatment in this situation because they are used as first-line agents in treatments of patients with agitated psychosis. In the emergency department setting, ketamine is also widely used to help sedate the patient, and it can be given intravenously or IM, intramuscularly. So both first and second generation antipsychotic medications can be used in acute management of agitated psychosis, often in conjunction with an anticholinergic medication to prevent possible extrapyramidal symptoms. So a clinician needs to gather appropriate history to determine if psychotic symptoms are present prior to the methamphetamine use, and if there's no evidence of any kind of pre-existing psychotic disorder, and if psychotic symptoms have remitted whenever the drug use is stopped, it is reasonable to try tapering the antipsychotic medication. The patient should be seen frequently during this period to assess for the reemergence of psychotic symptoms. So it's helpful to include a family member or a neighbor or roommate, some sort of source of collateral information who can report symptoms that they might observe as the antipsychotic is discontinued. Negative symptoms are usually not seen in methamphetamine-induced psychosis. So if that's seen on exam, it would suggest that a primary psychotic disorder requiring ongoing treatment is more likely. And here is a really neat little table by Hamilton and Fan, the pharmacologic treatment recommendations for methamphetamine-associated psychosis. The treatment of methamphetamine use disorder, which is what we're going to be focusing on for this patient because she's already been admitted and she's calmed down, is challenging. So even in patients who have not presented with psychotic symptoms, there's just not a drug that's been approved by the FDA for this indication. So non-pharmacological treatments form the basis for treatment of methamphetamine use disorder, which is what I would think this little lady has. Psychotherapeutic interventions such as cognitive behavioral therapy and contingency management have shown promise in the treatment of methamphetamine use. Cognitive behavioral therapy is a psychotherapeutic approach designed to identify and modify the dysfunctional or maladaptive behaviors and thinking patterns that cause and maintain addiction. So the fact that our patient has track marks on her arms indicates this is probably not the first time that she's used, and she probably does have a use disorder. So mental health providers need to focus, we need to focus specifically on the behavioral component of the cognitive behavioral therapy and use contingency management strategies to help change her behavior. The contingency management strategies, they're there to reinforce positive behaviors such as treatment adherence and abstinence by providing tangible incentives. Motivational interviewing techniques are proven to be effective in the treatment of addictions through the exploration of any ambivalence towards change. We're going to identify why don't you want to quit? And due to the interaction of thoughts and behaviors in the environment in which you operate, they have created this matrix model treatment approach aimed at integrating behavioral therapy, family education, individual counseling, 12-step support, drug testing, and encouragement for non-drug related activities. And it has been shown to be effective in reducing methamphetamine use. So I've already talked about some nurse practitioner interventions on the previous few slides, but for my little table here, I've got assess for and address underlying mental health problems such as anxiety or depression. They could be contributing to substance abuse disorder and psychosis. That is through direct clinical practice, and it is a tertiary level of management. We want to educate the patient on the use of drugs, the consequences on the health, safe practices, and wellness programs. That's an educational intervention, and that is primary. Treatments, we want to treat symptoms with medication. So if our patient is psychotic or, in need of medication, we would definitely give that to her. That would be direct clinical practice intervention, which is a secondary level of management. Psychosocial treatments, recommend them. Individual, group, and family counseling, that's a support intervention, which is tertiary. And we are also going to assist this patient to adapt to life without methamphetamines. Anticipate risk of relapse in order to prevent it. So that is a support intervention, which is tertiary. Role competencies according to Hamrick, direct care. We using evidence as a guide for practice and use of holistic perspective and formation of therapeutic partnership. We use guidance and coaching by engaging the patient in change to lead to a healthier life. We are going to use evidence-based practice to improve patient outcomes, and collaboration and ethical decision making to facilitate the patient, the family, the healthcare team, all getting together in conferences and meetings. So harm reduction. Harm reduction is an important consideration even in patients who are not ready to reduce or stop using methamphetamine, and PMHNPs can engage in treatment planning to reduce certain risks of chronic methamphetamine use. So for patients who inject methamphetamine, like our patient, we need to provide education on safer injection practices and linkage to syringe service programs to reduce the risk of contracting HIV, hepatitis B, and hepatitis C. A lot of patients who use methamphetamines, they have unsafe sex. We need to counsel on safer sex practices, including condom use. We need to offer like HIV pre-exposure prophylaxis like PrEP, and provide regular screening for sexually transmitted infections. We should also remember that other substances may be used in addition to meth, such as opioids, and counsel on the dangers of the drugs now, because fentanyl is in most of the illicit drugs purchased on the street. We also need to discuss chronic usage of methamphetamines can lead to hypertension and cardiovascular complications, and just maintain a therapeutic alliance, a non-judgmental approach, so that we can strengthen that effort at harm reduction and open opportunities for behavior change when these patients are ready to consider change. So long-term treatment of patients with methamphetamine addiction will likely focus on evidence-based behavioral therapies such as cognitive behavioral therapy, motivational interviewing, and contingency management interventions. An episode of methamphetamine-induced psychosis should not be regarded as a singular episode. So studies have suggested that a prior episode of methamphetamine-induced psychosis confers risk for further episodes. So our patient who's diagnosed with this disorder should receive ongoing treatment, follow-up, and care. Psychosocial treatment for methamphetamine use disorders have strong evidence base, and are considered the first-line treatment to reduce rates of psychosis by preventing relapse. They recommend an integrated, coordinated mental health and substance use service. Patients should ideally receive treatment for both conditions from the same clinical team during the admission period, which means as providers, we need to acquire the necessary skills that these guys need to keep them drug-free.